Hello, everyone. Welcome back to another session on advanced geriatric care. In this session, we will continue with our discussion on hematologic geriatric clinical care. Before that, let's review what we discussed in the previous session. We described normal age-related changes in hematologic and immune function, and we also explained how aging reduces bone marrow and immune reserve and limits stress response. By the end of this session, the learner will be able to 1. Recognize anemia in older adults, including atypical presentations and common causes. 2. Recognize bleeding and thrombotic risks in aging, including age-related coagulation changes. 3. Apply geriatric clinical reasoning to prevent hematologic deterioration. Let's continue by seeing how anemia present in older adults. Anemia is common in geriatrics and should never be dismissed as normal aging. Causes include nutritional deficiencies, chronic disease, renal impairment, bone marrow suppression, and occult blood loss. Anemia often presents atypically. Instead of dramatic symptoms, anemia may appear as fatigue, weakness, reduced mobility, falls, cognitive decline, or worsening heart failure. Because the impact on function can be significant even with mild anemia, early identification and investigation are essential to prevent progressive decline. Next is how bleeding and thrombotic risks change with aging. In bleeding risk, aging is associated with increased vascular fragility and altered platelet function. Medication use, especially anticoagulants and antiplatelet agents, further increases bleeding risk. Bleeding may present subtly as anemia, bruising, weakness, or functional decline rather than overt hemorrhage. In thrombotic risk, older adults have increased tendency toward thrombosis due to endothelial dysfunction, increased coagulation factor activity, inflammation, and reduced mobility. This increases risk of DVT, pulmonary embolism, and stroke. Having seen how bleeding and thrombotic risks change with aging, let's proceed to see how we can prevent hematologic deterioration. Hematologic deterioration has to do with the following. 1. Medication-related complications. Many medications affect hematologic function. Examples are anticoagulants, antiplatelets, chemotherapy agents, and some antibiotics. Polypharmacy increases risk of bleeding, cytopenias, and drug interactions. 2. Immune dysfunction and infection risk. Immune aging increases susceptibility to atypical infection presentation and reduced vaccine effectiveness. Infections may present as delirium, functional decline, or falls rather than fever or leukocytosis. 3. Functional decline as a hematologic signal. Functional decline often precedes laboratory abnormalities, reduced endurance, increasing dependence, or cognitive change may signal underlying anemia or immune dysfunction. Note that prompt hematologic assessment is essential. 4. Clinical reasoning focus. Advanced practitioners should routinely assess trends rather than isolated values. Consider medication effects. Evaluate functional changes. and anticipate the consequences of deterioration if left unaddressed. To summarize this session, it is important to know that, in older adults, anemia and hematologic risks often present subtly with functional decline. While aging increases, bleeding, thrombosis, and infection risks, making early recognition and proactive management essential. That's it for this session. Thanks for watching. See you in the next session.